Episode 1, Shame Disguised as Medicine, How 1953 Tried to Diagnose Girlhood. Before we jump in, I need to cover a few important things. First, the medical disclaimer. I'm a registered nurse. I am not your nurse. Nothing in this episode constitutes medical advice, a diagnosis, or a treatment plan for you or anyone in your life. The information I share today is for educational and informational purposes only. If you or someone you love is struggling with mental health, sexual health, adolescent development, or any kind of health concern, please reach out to a licensed healthcare provider. If you or someone you know is in crisis, call 988. That's the Suicide and Crisis Lifeline. Or go to your nearest emergency room. Real help from real professionals. That is always the move. Second, the content. Today's episode discusses outdated and harmful medical practices related to adolescent female development, sexuality, and the historical use of shame in medical literature. Some of what we discuss may be triggering for those who experience shame-based health and education, religious trauma around sexuality, or dismissive medical treatment as young people or as women. Take care of yourself. Pause if you need to. Come back when you're ready. This episode will be here. Third, the history. I reference a real medical text from 1953, a published pictorial medical guide. I'm analyzing it through a modern, evidence-based lens. My goal is not to mock people from 70 years ago for the sake of mockery. My goal is to trace the lineage of ideas that still affect how we treat girls and women in healthcare today, and to replace those ideas with some rooted in evidence, empowerment, and respect. All right, all the disclaimers are done. Buckle up. This one's going to hit a little different. A teenage girl's emotions were a battlefield. That's not me talking. That's a direct quote. Paraphrased, but essentially pulled from a 1953 medical guide, a real published book sitting on real bookshelves, being read by real doctors and real parents and real nurses who looked at their daughters and thought, yep, she's possessed. I'm not exaggerating. We're going to get into that word specifically, possessed, because they actually used it. Welcome to Battle Tested Nursing. I'm Nurse Mindy, and today we're doing something a little different. I took a 60-second script I wrote for a short-form video, a punchy little piece about a 1953 medical guide and what it said about teenage girls, and I thought, this deserves more than 60 seconds. This deserves a full conversation. Because what's buried in that old book isn't just outdated science. It's a philosophy of shame, a philosophy of control. And honestly, echoes of it are still bouncing around exam rooms and school counselor offices and dinner tables in 2026. So buckle in. We're going deep. We're going to unpack what this book actually said, why it mattered, how the medical establishment turned normal puberty into a moral crisis, and what we know now, with real evidence, real science, and hopefully a little bit of healing for anyone who grew up being told their body was the enemy. So let's get into it. So let me set the stage for you. The year is 1953. Eisenhower just become president. The Korean War is winding down. Elvis hasn't hit yet. That's still a couple of years away. TV dinners just become a thing. And in homes across America, there's this particular brand of medical literature that families kept on the shelf like a Bible. These big illustrated hardcover pictorial medical guides. They were basically the WebMD of their era. Except nobody was doom scrolling at 2 a.m. They were flipping through glossy pages with diagrams of the human body and chapters on everything from appendicitis to adolescence. And that's where our story begins. The chapter on adolescent girls. Now, I want to be fair here. I always want to be fair. 1953 was a different time. The cultural context was different. The scientific understanding was limited compared to what we have now. I get that. I'm not here to just dunk on old people for being old. That's lazy. That's cheap content. And that's not what we do here. But here's the thing. This wasn't presented as opinion. It was presented as medicine. It had the authority of the medical establishment behind it. And when you dress up cultural bias in a lab coat and put it on a bookshelf between chapters of heart disease and nutrition, it doesn't read like an opinion anymore. It reads like a diagnosis. So what did it actually say? It described a teenage girl's natural sexual feelings. And I mean the completely normal hormonal changes that happen during puberty as instinctive impulses that she had to learn to control, not understand, not even navigate, not process with the help of trusted adults. Control. Like they were a wild animal inside her that needed to be caged. And it went further. The book suggested that a girl's own conscience would tell her it was, and I want you to hear this word, wicked, to even think about sex. Not to have sex, not to engage in risky behavior, to think about it. The internal experience of being a developing human being was framed as a moral failure. Think about that for a second. You're 13 years old. Your body is changing in ways you don't understand. You're flooded with hormones that literally exist to prepare you for adulthood. And the medical book your parents trust, the one the family doctor might reference, is telling everyone around you that what you're feeling is wicked. That your own conscience could be punishing you for it. That's not medicine, but we'll get into that because it gets worse. The book didn't just pathologize the feelings. It pathologized the experience of going through it. It described adolescent girls, not as young people going through a development stage, but as beings experiencing something closer to, and I'm not being dramatic here, this is their framing, okay? Possession. The language suggested that puberty was something that happened to a girl, something that overtook her. She was being seized by forces that her fragile feminine constitution couldn't barely equipped to handle. And the expected outcome? A severe and prolonged emotional conflict. That was the prognosis. Not she'll have some mood swings and need support. Not this is a challenging but normal transition. No. The expectation was severe, prolonged conflict. As if suffering was baked into the design of being a teenage girl, and the best anyone can do was endure it. Okay. So that's the source material. That's what was written. That's what was believed, or at least what was published and distributed as medical guidance in 1953. Now let's talk about what was really going on. Okay. Here's where I need to put on my nursing hat. My evidence-based, peer-reviewed, I don't care about your feelings. I care about the data nursing hat. Okay. What that book described was not science. It was shame disguised as medicine. And that distinction matters enormously because when shame wears the costume of medical authority, it becomes almost impossible to question. You can push back against your weird uncle's opinions at Thanksgiving. You can even roll your eyes at a pastor who gets a little too specific about what God thinks about your body. But when a doctor tells you something, when a medical textbook says it, that carries a different weight. That gets internalized differently. That becomes part of your operating system in a way that's incredibly difficult to uninstall. So let's break down what was actually happening in 1953, culturally and medically, that produced this kind of thinking. First, the cultural piece. The 1950s in America were, on the surface, this era of prosperity and optimism. The war was over, suburbs were booming, the nuclear family was the ideal. But underneath that shiny surface was an incredibly rigid, incredibly anxious social structure, especially around gender and sexuality. Women had just been pulled out of the workforce after World War II. During the war, they'd been Rosie the Riveter. They'd been the welders and the factory workers and pilots. And then the men came home and suddenly the message was, thanks for your service. Now get back to the kitchen. There was an enormous cultural project underway to re-domesticate women, to put them back in a box. And that project started early. It started with girls. If you can convince a 13-year-old that her own developing sexuality was dangerous, shameful, and something to be controlled and suppressed, you weren't just managing her adolescence. You were programming her for a lifetime of compliance. You were teaching her that her body was not her own, that her feelings were not to be trusted, that the appropriate response to her own humanity was guilt. That's not an accident. That's a feature, not a bug. Second, the medical piece of it. In 1953, our understanding of adolescent psychology and the endocrinology was frankly primitive compared to what we know now. The field of adolescent medicine as a specialty barely existed. Most of what was written about teenagers was filtered through a lens of adult anxiety rather than actual research into the adolescent experience. Freudian, I hope I said that right, psychology was still enormously influential at that time. And Freud, for all his contributions to the field, had some deeply problematic ideas about female sexuality. The concept that women's sexual feelings were inherently more dangerous, more in need of sublimation and control, was baked into the psychoanalytic framework that dominated mid-century thinking. And here's the really insidious part, guys. There was very little research being done that centered the actual experiences of girls and women. The medical establishment was overwhelmingly male, The researchers were male. The textbook authors were male. The doctors reading those textbooks were predominantly male. So you had an entire system of knowledge production about the female body and the female psyche that was being created, validated, and distributed by people who had never experienced any of it. It would be like me writing a definitive guide to what it feels like to give birth. I'm a nurse. I've assisted in births. I've studied the physiology, but I have never been in labor. There's a fundamental experimental gap that if I'm not careful and humble about it, will lead me to say things that are clinically neat or humanly wrong. And that's what happened on a massive scale for decades. Third, the consequences. And this is the part that keeps me up at night as a healthcare professional. When you tell generations of girls that their feelings are wicked, that their bodies are battlefields, that puberty is a form of possession, you don't just create awkward teenagers. You create adults who can't advocate for themselves in medical settings. Women who delay seeking care for reproductive health issues because of deep-seated shame. Patients who can't accurately describe their symptoms because they were never given language for their own bodies that wasn't loaded with judgment. Mothers who unconsciously pass the same shame to their daughters. A generational cycle of medical mistrust, body shame, and emotional suppression. I see the downstream effects of this every single day in healthcare. Every single day. The women who don't ask questions about their diagnosis, the patient who apologizes for being difficult when she's literally just advocating for her own care, the teenager who won't tell her doctor what she's actually feeling because somewhere deep down she learned that her feelings were the problem. That's the legacy of books like this 1953 guide. The book itself is a relic. It's sitting in antique shops and estate sale boxes. I found mine in my grandmother's estate. But the damage is very much alive. And you know what's wild? Some people hear this and think, well, that was the 1950s. We've moved past that. Have we? Have we really? Think about it. In 2026, there are still school districts in this country teaching abstinence-only sex education. Programs where the primary tool is shame and fear, not information. There are still doctors who dismiss women's pain, who minimize their symptoms, who talk over them in their own appointments. There are still families where a girl asking questions about her own body is met with silence, discomfort, or punishment. The 1953 book is gone, but the philosophy behind it, that philosophy is stickier than we'd like to admit. Okay. I promise we weren't just going to sit in the darkness, so let's bring this into the light. Let's talk about what we actually know now. What the science actually says, because it's not just different from 1953. It's a completely different universe. Fact number 1, hormonal changes during puberty are powerful, but they are not a possession. Puberty is driven primarily by the hypothalamic pituitary gonadal axis, which is a fancy way of saying your brain starts sending signals to your reproductive organs to start producing sex hormones at a higher levels. In girls, that means increases in estrogen and progesterone. In boys, it's testosterone. In everyone, a whole cascade of physical, emotional, and neurological changes. And here's the critical thing. These changes are not a malfunction. They're not a disease. They're not a moral crisis. They are a normal, healthy, biologically programmed part of human development that has been happening for as long as humans have existed. Every single adult who has ever lived went through the same version of this. Your parents did. Your grandparents did. The guys who wrote that 1953 book did. The emotional intensity that comes with puberty, that's real. I'm not dismissing it. Adolescent brains are undergoing massive remodeling. The prefrontal cortex, which handles decision making and emotional regulation, isn't fully developed until your mid-20s. So yes, teenagers feel things intensely. They react strongly. They're navigating a world of new sensations and social pressures with a brain that's literally under construction. But that's not possession. That's development. And the appropriate response isn't shame. It's scaffolding, support, education, and patience. The same way you wouldn't shame a toddler for falling down while learning to walk. You don't shame a teenager for having big feelings while their brain is learning to regulate them. Fact number 2. Having thoughts and feelings about sex is not wicked. It's biology. Let me say that again for the people in the back, okay? Having thoughts and feelings about sex during adolescence is biologically normal. Period. End of clinical discussion. The hormonal changes of puberty are specifically designed, evolutionarily speaking, of course, to prepare the body for sexual maturity. That includes the emergence of sexual thoughts, sexual curiosity, and sexual feelings. This is not a design flaw. This is not evidence of moral corruption. This is your endocrine system doing exactly what it's supposed to do. Now, does that mean teenagers should act on every impulse? Of course not. That's where education comes in. That's where conversations about consent, about readiness, about safety, about emotional maturity come in. But there is a galaxy of difference between saying, let's talk about how to navigate these feelings responsibly, and saying, you are wicked for having them. One builds a competent, self-aware adult. The other builds a shameful spiral. And the research backs up this overwhelmingly. Studies consistently show that comprehensive, shame-free sex education leads to later initiation of sexual activity. Not earlier, which what the fear mongers always claim. It lowers rates of teen pregnancy, lowers the rates of sexually transmitted infections, higher rates of contraceptive use when sexual activity does begin. How about better communications in relationships? Higher self-esteem and body image. We can all use that. You know what shame-based approaches lead to? The opposite of all of that. Higher rates of risky behavior, more secrecy, less communication, more trauma. The data is not ambiguous here. Shame doesn't protect teenagers. Education does. Fact number 3. The goal isn't to create guilt and anxiety. It's to provide education, support, and safety. This is the framework shift that separates modern evidence-based adolescence care from the 1953 approach. The old model was suppression. Make them afraid of their own bodies and maybe they'll behave. The new model, the one that actually works, is empowerment. Give them knowledge. Give them language. Give them trusted adults, and they'll make better decisions. And I want to be clear. This isn't some radical progressive agenda. This is what every major medical and psychological organization in the world recommends. The American Academy of Pediatrics, the World Health Organization, the American Psychological Association, the Society for Adolescent Health and Medicine. This is mainstream, evidence-based, peer-reviewed consensus. When I say evidence-based, I mean there are decades of longitudinal studies, randomized controlled trials, and meta-analysis. The gold standard of scientific evidence. And all pointing in the same direction. Teens do better when they're informed and supported, not shamed and suppressed. Fact number 4, and this is a big one, guys. The real conflict was never inside the girls. This is the framework I want to leave you with, because if you take nothing else from this episode, take this. That 1953 book described teenage girls experiencing a severe and prolonged emotional conflict. And you know what? They probably were. But the conflict wasn't between their instinctive impulses and their conscience. The conflict was between who they naturally were and the impossible, oppressive, shame-based rules of the world that they lived in. Imagine being told that the most fundamental aspects of your developing self, your feelings, your curiosity, your body, are dangerous and wicked. And then being told that the resulting anguish is just part of being a girl. That it's just your cross to bear. That it's medical fact. Of course, there were emotional conflict, but the pathology wasn't in the girls. The pathology was in the system that couldn't tolerate female anatomy, the system that needed girls to be uncomfortable, the system that dressed up social control as science and called it medicine. So what do we do with all of this? Because I don't want to just leave you with a history lesson and a bummer. I want to give you something actionable. Whether you're a parent, a healthcare provider, a teacher, or someone who just is now realizing that some of this weird guilt you've been carrying might not actually be yours. Here's what I think matters. If you are a parent or caregiver, start the conversations early and keep them going. I know it's uncomfortable, I know. But your discomfort is not more important than your child's well-being. And here's the thing, it gets easier. That first conversation is the hardest. After that, you're just talking. You're building a channel of communication that your kid will use when they are actually need it. And they will need it. Use correct anatomical language. I cannot stress that enough. When When we give kids cutesy euphoriums of the body parts, we're sending the subtle message that those body parts are somehow too shameful to name. A vulva is a vulva. A penis is a penis. It's anatomy, not profanity. And practically speaking, children who know correct anatomical terms are better able to communicate with healthcare providers and critically better able to disclose abuse if it happens. That's not just a philosophy, that's a safety issue. Parents, check your own baggage before you have that talk with your kid. Have a talk with yourself. What messages did you internalize growing up? What shame are you carrying that you might accidentally transmit? You don't have to be perfectly healed to be a good parent. None of us are. But you do need to be aware of what you're bringing to the table. If you're a healthcare provider, language matters. The words we use in clinical settings carry enormous weight. When we describe normal developmental processes with language that implies pathology or defiance, we do harm, and even unintentionally. Be intentional about using neutral, affirming, accurate language. Audit your own vocabulary. Ask yourself, if I were a scared 14-year-old hearing this for the first time, would these words make me feel safe or ashamed? Create safe spaces. Your patient should feel safe enough to tell you the truth. If they're not telling you things, it might not be because of nothing is happening. It might be because your office, your tone, your intake forms, or your body language, your everything is sending signals that certain topics are unwelcome. Look at your environment through the patient's eyes. Stay current. The science evolves. What we are teaching even 10 years ago has been refined and updated. Commit to continuing education around adolescent health, sexual health, and trauma-informed care. It's not optional. It's our professional and ethical obligation. If you are someone who grew up with shame, I want to talk to you for a second. Specifically you. If you grew up being told explicitly or implicitly that your body was dangerous, that your feelings were wrong, that your natural development was something to be ashamed of, I want you to hear this clearly. That was not your fault, and it was not true. That was not your fault, and it was not true. Whatever you were told by a book, by a parent, by a church, by a doctor, by a culture, if it made you feel broken for simply being human, it was wrong. Not you, it. And I know that hearing that from a podcast isn't going to undo decades of internalized messaging. I'm not naive. Shame that deep doesn't dissolve because someone on the internet said nice words. But I do think it matters to name it, to say it out loud, to put it on record, because sometimes healing starts with someone simply saying, that thing that happened to you, it shouldn't have happened, and it wasn't your fault. You're not broken. You were never broken. You were just a person growing up in a world that didn't know how to handle you without trying to control you. If this is resonating and you feel like there's work to do, worth that goes beyond a podcast episode, I encourage you to seek out a therapist who specializes in shame resilience, body image, or trauma. The work is worth it. You are worth it. If you're a young person listening to this, first of all, hi, thanks for being here. The fact that you're listening to something like this tells me that you're curious and thoughtful and probably way more mature than anyone gives you credit for. Here's what I want you to know. You are allowed to have questions. You are allowed to have feelings, and you are allowed to take up space in your own body. If the adults in your life aren't giving you good information, seek it out from trusted sources, evidence-based websites, school counselors, healthcare providers who make you feel safe. The amaze.org website, which was incredibly age-appropriate content, there are people who want to help you navigate this stuff without shame. You deserve that. And if anyone makes you feel like your normal human development is something to be ashamed of, I want you to remember this. The problem is not you. The problem is a very old, very stubborn, very wrong idea that refuses to die. You are not a battlefield. You are a person, and you deserve to be treated like one. You know, I started this episode because of a 60-second video script, a short form piece about a weird old book from 1953. And somewhere along the way, it turned into this, because that's what happens when you pull on a thread like this. It unravels into something bigger than you ever expected. This isn't really about one book. It's about how medical authority shapes culture. It's about the things we call science in one era become the things we call oppression in the next. It's about the responsibility that comes with having a platform, whether you're a textbook author in 1953 or a content creator in 2026. Throughout history, medicine has been used to justify some of the most harmful ideas about women and girls. From the ancient Greek concept of the wandering uterus causing hysteria to the Victorian era practice of institutionalizing women who were too emotional, to the mid-century shame machine we've been talking about today. There is a long, ugly tradition of using medical authority to control female bodies and female minds. And every single time, the person in power said the same thing. This is just science. This is just medicine. We're just trying to help. That should give us some pause. Not because medicine is bad. Medicine is extraordinary. And I've dedicated my life to it. But because medicine is practiced by humans, and humans have biases, humans have blind spots, humans have agendas, and when those biases and blind spots and agendas get embedded in medical practice, the consequences are devastating. Because people trust us. Patients trust us. And that trust is sacred. I started battle tested nursing because I believe healthcare information should empower people, not shame them. It should be based on evidence, not tradition. It should serve the patient, not the institution. And it should be accessible, not locked behind jargon and gatekeeping and the assumption that regular people can't handle the truth about their own bodies. That 1953 book, it was the opposite of all of that. It took vulnerable young people and told them they were the problem. And it did it with the full authority of the medical establishment. We can do better. We are doing better. But better isn't done. And every time we look back at something like this and say, wow, how did they ever believe that? We should also be asking, what are we believing right now that future generations will look back on in the same way? That's not a comfortable question, but it's an important one. And I'd rather ask uncomfortable questions than repeat comfortable mistakes. Before I close out, let me bring the disclaimers back around because they're important every time. Everything I discussed today is for educational and informational purposes only. I shared historical context, modern research, and my perspective as a nursing professional. This is not a substitute for individualized medical care or mental health treatment. If anything in today's episode brought up difficult feelings or memories, please don't sit on that alone. Reach out to someone. Resources are listed in my caption below. BattletestedNursing.com for our future nurses, which is a continuously building library of evidence-based study resources, peer-to-peer mentorship, motivation, and much more. You are not alone. Help is available. And asking for help is not weakness. It is one of the bravest, most self-aware things a person can do. All right, that's the episode. If you made it this far, thank you. Genuinely, from the bottom of my heart. This one meant a lot to me, and the fact that you gave it your time and your attention means more than you know. Here's what I want to leave you with. Navigate your health with facts, not fear. That's the whole mission. That's the whole reason this historical comparison series exists. Whether it's understanding puberty, managing a chronic condition, advocating for yourself in an ER, or just figuring out what's normal and what's not, you deserve evidence-based information that empowers you. Not information that shames you into silence. Not information that makes you afraid of your own body. Not information designed to keep you small and compliant. You deserve better than that, and we're here to provide it. If that resonates with you, come find me, Nurse Mindy, and Battle Tested Nursing on social media and www.battletestednursing.com. That's where I put everything from the resources, study guides, breakdowns of it all, built for real people, backed by real evidence. No gatekeeping, no judgment, just information you can actually use. Now, real talk for a second. I need to have an honest conversation with you because that's what we do here. We keep it real. We're building something new. And I don't just mean a podcast or a website. I mean a community. A space where nursing students can come together and be honest and have evidence-based conversations without the gatekeeping and without the shame. A place where asking questions is celebrated, not punished. A place where your health literacy is treated as your right, not a privilege. But here's the truth. And I'm just gonna be straight with you because I respect you too much to have anything else. We need your help to grow this. Before we can turn this into something sustainable, before we can keep the lights on, keep producing episodes, keep developing resources, and keep investing in the platform, we need people to find us. We need reach. We need you to help spread the word. So if this episode meant something to you, if it made you think, if it made you feel seen, if it made you want to send it to someone, please do it. Don't just think about it. Do it right now. Here's exactly how you can help. Like this episode. Whatever platform you're on, hit that like button, hit the heart, give it a thumbs up. It takes 1 second and it tells the algorithm that this content matters. Subscribe and follow. Turn on notifications. Don't let the algorithm decide if you see our content. Take control of that. Subscribe so you never miss an episode. Share this episode. This is the big one. This is the one that changes everything. Send it to a friend. Text it to your sister. Post it on your Instagram story. Drop the link in your Facebook group. Share it to your nurse group chat. Tag someone who needs to hear this. Every single share puts this in front of someone new. Someone who might be carrying 40 years of shame from exactly the kind of thinking we're talked about today. You could be the reason they hear for the first time that it wasn't their fault. Leave a comment, engage with us. Tell us what you think. Tell us your story. Ask questions, push back, agree, disagree. The conversation doesn't end when the episode ends. It starts here. Every like, every share, every subscribe, every comment, it matters more than you think. It's how the algorithm finds us. It's how new listeners discover us. It's how we go from a passion project to a platform that can actually make a difference at scale. You are literally marketing our marketing department. And I don't say that lightly. I say it because it's true and because I trust you to show up for this the same way I'm showing up for you every week. And speaking of every week, let me tell you when to find us. This show, the deep dives, the history, the evidence-based breakdowns, everything you heard today, new episodes drop every Thursday at 8 p.m. Sorry. That's your Thursday night appointment with Real Talk with Nurse Mindy, the historical series. Set an alarm. Put it on your calendar. Grab your coffee, your wine, your protein shake, your emotional support water bottle, whatever your vibe is, and settle in with us at 8 o'clock. But, and this is big, if you want even more, I've got something else for you. Real Talk with Nurse Mindy, the Nurse Warrior interview series, where I sit down with real nurses and have raw, honest, no filter conversations about their nursing school experiences, their challenges, how they overcome them, and what it's actually like in the trenches of healthcare. The stuff they don't put in the brochures, the stuff they don't teach you in nursing school, the stories, the burnout, the breakouts, and the breakthroughs, the ugly cries in the supply closet, the moments you remind you why you got into this field in the first place. That airs every Tuesday at 8 p.m. So here's your weekly lineup. Tuesdays at 8 p.m., Real Talk with Nurse Mindy. Nurse Warrior interviews, raw and real. Thursdays at 8 p.m., Real Talk with Nurse Mindy, the historical series. Welcome to Real Talk with Nurse Mindy. And I'm Nurse Mindy, broadcasting from Iowa. This